Okay, hi everyone. Welcome to our Canadian Guidelines for Post-COVID Condition webinar series. We're super excited to have you all here today. My name is Heather Travis. I'm the Science Manager for Cochrane Canada and the CAN-PCC project, and I'm excited to be your host and facilitator for today's session. Joining me today are three outstanding collaborators for the project. We have Dr. David Kaplan, Dr. Nancy Santesso, and Guyane Beaulieu. Together, David, Nancy, and Guyane will be walking you through the recommendations related to healthcare services, systems, and social support from the Canadian Guidelines for Post-COVID Condition. Here is some information about your speakers today. So Dr. David Kaplan is a CAN-PCC Guideline Development Group member and co-chair of the Healthcare Services, Systems, and Social Support Guideline Team. He is also an associate professor in the Department of Family and Community Medicine and Joint Center for Bioethics in the Temerity Faculty of Medicine at the University of Toronto. He is also a family physician at North York General Hospital and the Vice President of Quality at Ontario Health. Dr. Nancy Santesso is the CAN-PCC co-chair for the Healthcare Services and Systems and Social Support Guideline Team. She is an associate member in the Department of Health Research Methods, Evidence, and Impact at McMaster University, and she is also the Deputy Director of Cochrane Canada. We have Guyane Beaulieu joining us. She is our CAN-PCC patient representative on the Guideline Development Group and on a guideline team. Before we begin today, it's important to acknowledge the work that CAN-PCC takes place across Canada, a land that is the traditional, ancestral, and unceded territory of many Indigenous nations. From coast to coast, these lands are home to the First Nations, Inuit, and Métis peoples who have stewarded them for millennia. We honor their rich cultures, languages, traditions, and histories. For our McMaster University presenters, we recognize that McMaster sits on the traditional territories of the Mississauga and the Haudenosaunee nations within the lands protected by the Dish with One Spoon Wampum Agreement. I just want to go through a few webinar housekeeping rules for today's webinar. Please submit your questions using the Q&A feature. We're going to keep an eye on the chat as well, but the Q&A is your best resource for submitting questions. Wherever possible, slides are presented in both English and French. For more complex slides, though, we'll present the English first, followed by the French. A recording of the webinar and the slides will be available on canpcc.ca within a week or 10 days time after this webinar. So I'm now going to pass it over to Dr. Kaplan.
Thank you so much. It's really our pleasure to be here this afternoon, I guess already, at least here in Toronto time now. Today, as you've heard, we're going to discuss the Canadian guidelines for post-COVID-19 condition as they relate to one of the guideline teams, which was the one for healthcare services and systems and social support. And with me today is my co-chair as well as one of our patient partners. If we go to the next slide, you can see our disclosures. The project itself was made possible through a substantial financial contribution from the Public Health Agency of Canada. I receive salary support from Ontario Health, and Guyane is a member of the steering committee from the research network CME. Next slide. So we have three objectives this afternoon. The first is to share evidence-based post-COVID condition recommendations related to healthcare services and systems as social supports. The second is to share how the CAN-PCC guidelines can be incorporated into policy and practice. And lastly is to increase the awareness overall of the CAN-PCC guidelines. So I'm going to start this afternoon by talking a bit about and level setting around post-COVID condition. Long COVID or post-COVID condition is a relatively new and complicated illness affecting various different parts of the body. What's important for all of us to know is it shows up in different ways in different people and it can be very mild to severe, and it can last for various lengths of time. Different specialties and medical fields are providing care in different places, in hospitals, in clinic, and in rehab centers. The recommendations that we are presenting today reflects and captures what we believe the most up-to-date and current evidence. The Post-COVID Condition Guideline Committee applied the World Health Organization definition of post-COVID condition. This is a new illness, as I mentioned, and we're still learning about it. But this is the official definition according to the World Health Organization. It usually appears within 3 months from acute COVID-19 infection and has to last at least 2 months. Symptoms can vary and can change or worsen over the time period and need to significantly impact daily life. Next slide. The prevalence of long COVID, as it's been reported most recently, is about 400 million people in the world have had some sort of constellation of symptoms that represents post-COVID-19 condition. In Canada, it is believed that 1 in 9 adults, or about 3.5 million Canadian adults, have experienced long-term symptoms after a COVID-19 infection. This could be something as relatively minor as prolonged cough or lack of smell, or much more significant with ongoing issues related to post-exertional malaise. It's believed that 600,000 adults in Canada with long-term symptoms of post-COVID-19 have missed days of work or school. Next slide. Post-COVID-19, as I mentioned, is a very complicated condition. There are over 200 reported symptoms related to post-COVID-19 condition, but the most common in the literature are fatigue, pain, shortness of breath, brain fog, sleeping problems, and post-exertional malaise. So now, at this point, what I'd like to do is hand it over to Guyane, who is one of our patient representatives, to tell us a little bit more about her experience.
Well, thanks, David. Hi, I'm from Quebec, so you'll see I have my thick Quebecois accent. I first got sick with COVID 4 years ago, and it flipped my life upside down. Prior to getting sick, my body never really stopped me from doing what I wanted to. Now, all of a sudden, I was unable to walk to the kitchen or withstand a conversation. But I'm still one of the lucky few who see slow improvements every year, while carefully pacing my energy. Just to give you an idea, the first year I was bedbound. The first 2 years I was constantly too exhausted to laugh. But up until the 3rd year, I was only seeing my friends and family as a social obligation, afraid I would be forgotten otherwise. But I was still too exhausted to enjoy myself. It was hard, and it's still hard. But now I can cry tears of grief and joy when I catch myself able to dance for a minute. I'm still disabled, living a fraction of the life I used to. But I'm one of the lucky few with enough energy to process my emotions as they come and to work part-time from home with accommodations. I used to work outside in the summer heat as an archaeologist. But now, like hundreds of thousands of other Canadians, I can't withstand the heat, and I often need a wheelchair to leave the house. I won't have kids, and I'm afraid I'll never be able to run again. Long COVID is debilitating. But I found meaning in co-administrating the Facebook support group COVID Long Quebec Long COVID. With each new wave of infection, we see hundreds of people getting robbed of the life they knew. And I found meaning in sharing my experience with them, learning about their experience, and together helping to find safe, science-based information to help navigate our new situation. because infection-associated chronic conditions are not new, but they're still misunderstood. Many people are still not believed, still not being taken care of, and still facing ableism. The lack of access of and the need for safe and official guidelines on managing long COVID is what inspired me to get involved with CAN-PCC. As someone with lived experience, I was able to bring our voice and perspective while we crafted our recommendations, and with the same weight as the other specialists around the table. The CAN-PCC collaborative tried to contextualize each recommendation with remarks and implementations to help patients and health professionals in making informed decisions. Our work often highlighted the need for more research, as the strength of our recommendation depends on the quality of the data. There is a need for more and better research with patient involvement at every step of the process. And for millions of people worldwide, research is our only hope of a better quality of life. And hopefully, I'd be able to run again. Thanks, David. Back to you.
Thanks,
You
Guyane.
so
Yeah, that's great.
go ahead, Nancy. I was going to hand it over to you. So go ahead.
Okay, good. Thanks, Guyane. It has been incredibly valuable having you on our team. So as David said, we are focusing, our recommendations today are focusing on health systems levels and healthcare levels. We have lots of other groups that are doing information about how to treat specifically. But one of the reasons we're focusing on the health system level is because we know that only about 1 in 8 adults in Canada who need support and seeking support did not feel that they received appropriate care. So only 1 in 8 thought that they did receive appropriate care. And so that's why we're focusing on the healthcare system level questions. Next slide. So this large group of people, of organizations through the Public Health Agency of Canada, as we said, lots of funding from them to do these guidelines, came together to help improve the post-COVID-19 condition. Next slide. And there were over 150 people across all of our groups who were making recommendations. People from different areas of research and care, people involved in guidelines, people who are also involved in making sure we put these recommendations together and then make sure they have an impact in the future. So many different people were involved. Next slide. In particular, we had persons with lived experience, as Guyane mentioned, allied health professionals, so therapists, occupational therapists, physical therapists, clinicians, physicians. We had people who provided us feedback about the costs and resources that were necessary, researchers, nurses. So a diverse range of experts were involved. Next slide. And as we said, so in our group and also all the groups that came up with recommendations, we had actually 2 people who with lived experience who were providing their feedback. And as Guyane said, hopefully it was very rewarding for them. We really wanted to make sure that their voice was heard in the process. Next slide. The other key points when we were developing the recommendations were we wanted to make sure we had voices from many people that are involved in post-COVID care and the people with lived experience. We made sure to collaborate with other key groups in the area of research and care. We wanted to make sure we based all of our recommendations on evidence, so an evidence-based approach. Certainly important in all guidelines is to make sure that no one had any conflicts of interest. So we had a whole system in place to make sure that there weren't possible other agendas involved in making these recommendations. And we also wanted to make sure everyone felt comfortable contributing to it and felt that they had adequate training to do that. So we provided that as well. Next slide. What we do know, and part of what we've been doing, especially in Canada in these times, making sure to include important information, consider what is happening in many groups across Canada. So you can see this very long list of all the special considerations that we had to make sure that we included these points when we made our recommendations. And we had a whole separate group that was focused on reading our recommendations to make sure that they did have an equity lens, if you can say. Next slide. So we had all these 150 people involved. What we did at the beginning of our project was we made sure to consult with these 150 people and even more people to determine what were the most important areas where we needed recommendations. So if you look at this list, you can think of the typical ones: prevention. How do we prevent post-COVID conditions? Testing. How do we diagnose it? How do we treat it with pharmacological treatments or non-pharmacological treatments? Were there any psychological implications or neurological issues that needed to be dealt with? How does this apply to pediatrics and adolescents? It's not just happening in adults. And then finally, our category that we're going to talk about today was about the health services or systems, or what support is needed for patients and people with long COVID. Next slide. We obviously, we wanted to do all of these recommendations, and we looked for all of the evidence that we could find. This from our chief science advisor. While scientific studies are being done, and while this evidence is growing in this field, because it is a new condition, we still need to provide some guidance about what clinicians and healthcare systems can do. What can patients and people living with post-COVID do to help themselves? So it was important to do something now and not later until we had even more evidence. Next slide. So as I said, we had a long process. That very first part in the process was selecting what our topics and questions are. And as I said, we really wanted feedback from government, patients and the public, people with lived experiences. We consulted with healthcare organizations to really find out what were the most important topics and questions. As we went down, we consulted with these groups. Even when we made the recommendations, we put it out and said, as a survey, and said, please provide your feedback about these. And many times we would put out a recommendation. We might have over 1,000 people providing comments, and we looked at all of those comments to make sure that our recommendations made sense, and again, covered what people really wanted to know about. So this whole process of deciding what to do, what do we want to cover, making the recommendations, making sure that they're the right recommendations worded in a good way, and then finally approving them and working on how to make sure they are used by clinicians and people out there. Next slide. So before we get into the details of our recommendations, you may have seen before, but there are recommendations that we developed. We either came up with, if you look at the left-hand side of the slide, we either came up with strong recommendations or we came up with conditional recommendations. And we could have recommended to do something. On the right-hand side of the slide, we could have recommended to do something, or we sometimes recommended to not do something. So we have these strong recommendations where we might have said, we recommend you do this. We recommend the government does this. So we had strong or conditional recommendations. Next slide. And then in some of our recommendations, as David will explain, some of the recommendations also, they will have a qualifier saying, how much evidence did we really have? How sure are we about the evidence that we have when we made that recommendation? So you'll see high certainty evidence or low or moderate or very low certainty evidence underneath all of our recommendations. And that really is speaking to how sure are we about this evidence. And it's perfectly acceptable to be able to say to groups, you know, we've made this recommendation, but we're not absolutely certain. We have low certainty in this evidence, and that's good for people to know. Next slide. And we also have some idea and some literature around how do we interpret this evidence that we found and these recommendations that we provide. And so we do come up with a little bit of a rubric to follow. And I would say, let's focus on the right-hand side, because most of the recommendations that came out of this CAN-PCC project were conditional. And so what does that mean? It means for someone who is living with post-COVID, it means that when they see a recommendation and it says, you know, we have a conditional recommendation, we suggest you do this. We know when we made that recommendation that most people would want to follow that recommendation, but it's something that you would discuss with your healthcare provider to see if you really would follow that recommendation. There may be some other considerations that come into place. I'll skip down to policymakers because that's the most important target of these recommendations, where we said, you know, we suggest doing this, but we recognize that policymaking, there'll probably be a little bit more discussion about whether to implement it and how to implement it. And it may depend on resources, feasibility, and other factors. But most of ours were conditional recommendations. Next slide. And I guess I'll leave it up to David to go through some of the specifics of the recommendations that we came up with.
Thank you so much, Nancy, for an overview of what I would say was such a robust process to get through to the recommendations that I'm going to be able to share with everybody now. So our first recommendation is actually what we call a good practice statement. This one was really about providing training to professionals. The collaborative statement says that healthcare educators in Canada should provide training to healthcare professionals and trainees to build knowledge, skills, and competence to recognize and validate people's symptoms associated with post-COVID-19 condition. This is a good practice statement, but the good practice statement really feels that different methods of supports could be made available depending on the available resources, the cost, the effectiveness, the relevance. And these resources to clinicians should be accessible, appropriate, and importantly, culturally appropriate and culturally responsive. The second recommendation or the second item that I'm going to talk about is actually one of the first recommendations, not good practice statements. So I'll have the slide skip forward to the first one. So this one is around healthcare services and systems and social support. And this was whether or not in-person or virtual visits should be used for people with post-COVID-19 condition to receive care. And so after looking at the evidence, the collaborative suggests that either in-person or virtual appointments for people with post-COVID-19 condition should be available to receive care. This is a conditional recommendation with low certainty of evidence. Virtual appointments are really important to enhance access to care for people who otherwise may not be able to for reasons of disability or prefer not to come to the clinic in person. You can imagine this being the case for people with post-COVID-19 condition during periods of peak respiratory illnesses. And virtual appointments in this recommendation include the synchronous communication like video or phone, but also the asynchronous like chat and email, and that these are tailored to the individual and ensuring feasibility. There's a separate recommendation on whether or not virtual rehabilitation versus in-person rehabilitation for people with post-COVID-19 conditions should be offered. So we'll move on to the next recommendation. The next recommendation is looking at the concept of chronic disease self-management or self-care. And the CAN-PCC collaborative suggests that programs to improve self-care be provided to people with post-COVID-19 condition. Again, a conditional recommendation with very low certainty in the evidence. As I mentioned, these are interventions that are programs that provide information and education to improve a person's ability to manage their symptoms and treatment of their condition, so they become active participants in their care, and to improve their physical, psychological, and social outcomes. Self-care interventions can be provided in a variety of different formats, in group, for instance, and with different contexts, which also may evolve as we have a better understanding in general of what it means to live with post-COVID-19 condition. These self-care programs are also provided in the context of receiving other care, and often can be combined with other self-management programs for other chronic diseases. Next slide. The next recommendation is around the use of care navigators. I have to say this was very surprising to me in looking at the evidence as one of the co-chairs of this committee. And you'll see in a minute a very low certainty in the evidence. And the conditional recommendation here is that we suggest that care navigators be used for people with post-COVID-19 condition, but there's very low certainty in the evidence. A care navigator could be a healthcare professional or someone with experience with or training about the healthcare system or social care system, who coordinates contact with care providers. They don't actually provide care, to assist people with overcoming burdens to their care and to make sure that they receive their care in a timely and appropriate way. Next slide. Lots of recommendations, lots of opportunity to ask questions about these recommendations afterward as well. The next recommendation is around multidisciplinary workplace interventions. So the collaborative suggests that multidisciplinary workplace interventions be provided to people with post-COVID-19 condition who've been unable to return to work. This is a conditional recommendation, again, with very low certainty in the evidence. Multidisciplinary workplace interventions can include interventions like changing the workplace, modified tasks, interventions aimed at the person, like clinical or psychological, physical, or socioeducational interventions. And these interventions should be tailored to the individual with the idea of getting them back into the workplace, including adaptations to their work to avoid relapses due to things like post-exertional malaise. The next recommendation, the final one that I'm going to highlight, is the education of healthcare professionals about post-COVID-19 condition. And we suggest that the education of healthcare professionals with post-COVID-19 condition be provided using either printed or online education materials, lectures, and workshops, either in person or virtual, and outreach visits rather than other methods. This is a conditional recommendation, once again, with a low certainty of evidence. Really, while we know the choice of method will be dependent on the preference of the learners, resources and feasibility, printed and online material require few resources, can reach a wider audience, and therefore may result in greater impact compared with other methods like in-person small group education. And coordination of educational activities across programs and jurisdictions, and creating that content based on sound pedagogical techniques is essential. It wouldn't make a lot of sense for us to try to decentralize this education and almost have multiple groups working on educational material. It would make way more sense to have a concerted effort in creating that material for healthcare providers across the country. I think we're now going to move on just to a couple other items before we go on to questions. If anyone is interested in the larger recommendation map, if you go to the CAN-PCC website, you can see all the recommendations based on our recommendation map. And you can drill down and see the detailed deliberations around how the committee got to those recommendations. We also on the website have plain language recommendations, and this is a format that summarizes the recommendation, but also the key supporting information in a user-friendly one-page view. Just from the purposes of this webinar, we couldn't go into a lot of the detail around how we got to these recommendations, but all of this is summarized in what we call plain language on the CAN-PCC website. Lastly, before we open it up to questions, I would highlight the resources that are available for patients. They're here on the website. There are a number of webinars that the collaborative, including today's webinar, that will be available or already available, and then some additional interactive infographics and online resource sheets available on that webpage. So I want to thank my co-panelists for joining today, and now we will open it up to questions. I think there was a question in the chat as opposed to the Q&A button, so I'm not.
Yeah, so we did receive one question that was submitted in advance, and it was, if the evidence is limited and low certainty on many of these recommendations, then why are we disseminating them?
So I think that's an excellent question. I think this is one of the reasons these were what we call conditional recommendations. Nancy, I don't know if you want to go, you did, I think, a good job originally explaining what a conditional recommendation is. Maybe we should just sort of go over it again.
Sure, we could go. Are we able to move the slide back to that part?
Ooh, I just saw it.
And I actually, yeah, we could start here first. I think
Sure.
when we came up with a lot of the evidence that we had, we didn't have a lot of evidence, or we had to use evidence from other conditions. So we didn't have evidence necessarily in people with post-COVID conditions, but we might have had some evidence in people who had respiratory diseases or had other disabilities. So we tried to look for all of that evidence that could have been used to help answer our questions. And I think, we definitely had, most of our recommendations had low certainty or very low certainty. We were not sure about the benefits and harms. But low certainty means if we found some benefits, those benefits may happen. It also means that the harms may happen too. And so then our group had to say, okay, if we had to balance these benefits to the harms, even though we're not sure, we have some uncertainty, do these benefits as we know them today outweigh those harms? And if we made a recommendation to possibly do something, to suggest to do something, we had to make sure that we thought that the benefits outweighed those harms. So even though we had uncertainty in those benefits and harms, at least we knew that there would be more benefits than harms in that uncertainty. So we definitely, we're in that area where we aren't sure. But part of that balance is, okay, overall, do we think that there's going to be some benefit? And then you can see, if we do go to that slide where it outlines how clinicians and patients and policymakers, you can see that, we suggested that they do it, made a conditional recommendation. And it was with the understanding that most people would want to do it. And that's because the benefits outweighed the harms of what we could tell. And again, even for policymakers, they would say, okay, well, we're on the side of doing it. Are there other factors that could even weigh even more? So that's where that debate could come into play. The feasibility, the cost, etc. But overall, there was more benefit than harms. And so that's why we felt comfortable going ahead with making these recommendations. David, I don't know if you want to add anything else.
Yeah, I mean, I think there's a lot of areas in medicine, when I'm after this, I'm going to be seeing my afternoon clinic. There's a lot of areas in medicine where we don't have strong evidence, and that's why patients come to see us as healthcare clinicians, to lay out the risks and benefits once we have a diagnosis of a particular approach to their care. Sometimes we have lots of evidence, and it makes it very easy to recommend something as a course of action. But that's when, shared decision making is so important at the level of that individual patient and their care clinician. If we made a recommendation against, it would mean that we are arguing that physicians shouldn't, or nurse practitioners shouldn't even offer that form of treatment to their patients. But a conditional recommendation really means that most people are going to want to discuss that with their healthcare professional first. I also think it's important, strong recommendations allow a group like this collaborative to make recommendations for adoption to policymakers. I think that's much more difficult with conditional recommendations because there's, as Nancy mentioned, so many other factors. You have to balance all sorts of other societal healthcare pressures, what to fund versus what not to fund. It doesn't mean that we shouldn't look at them, but there's a definite difference between thinking about adopting something at a policy level when there's a conditional versus strong recommendation. So I think this is actually a very important slide to understand the difference between those strong and conditional recommendations. Sometimes I think about the conditional recommendations as almost hypothesis generating. It's one of those, when you were a young student, you'd say further research is required to, to validate the question that I'm trying to discuss. But yeah. Any other questions?
There were some questions that came in advance, but they were related to brain fog and physical activity, which are related to the diagnosis and testing as well as the intervention. So for people who submitted questions around those guidelines that are not related to the health services today, those recordings are available on the website. And so you can listen to those webinars as well. They're in both languages. And then the recommendations for those topics that you're interested in around brain fog and cognitive health and physical activity, those can be found on the rec map.
I think, Heather, one thing to mention about those, though, I didn't see those questions specifically, but we might say that, when we were doing these recommendations, part of our, the benefits that we were looking for were definitely to help reduce those symptoms of post-COVID conditions. So though we would say, okay, well, is a virtual appointment going to help reduce those symptoms? Because those were the critical outcomes and critical benefits and harms that people wanted to make sure that we were looking at those, when making our recommendations.
Okay, we have another question in the chat about how are we consulting international researchers and best practices for PCC across other countries on care and treatment and how that happens within their systems.
Heather, could I jump in? And David, maybe you could say more.
Yeah, go ahead, Nancy. Yeah, for sure.
Yeah, I know. So we actually have an international advisory group that is involved with looking at our recommendations and also providing feedback about how we were doing our recommendations, so the process. So That international advisory group includes people who are representing organizations across the world. So we had people from the World Health Organization, people from the UK guideline group, from the American guideline group. So we definitely involved them in the process, because ideally we would really like these recommendations to be similar across the world. You know, we in Canada, when we were making them, we said, do we need to consider some other factors that are happening globally? And so that was definitely something we decided at the very beginning of this project, that we need international collaborators also.
Thank you. And then we have another question about how effective has advocacy been with policymakers and funders?
Yeah, so let me just see if I can look at that more closely too.
Has the approach been pan-Canadian?
Well, I think what I would say is, you know, we just released, we're just coming to a close of this project, and we just released, you know, over, I think it's 100 recommendations and good practice statements from the whole project. I think it'd be too early to say, you know, what the effectiveness is. I think the role of the guideline group is to think about not advocacy as much as knowledge translation. But you know, there's a whole piece of work around implementation of guidelines that comes after one has best practice guidelines. And so I think we're sort of still at that. We've developed the guidelines. This piece of work is coming to an end. And then the question, I think, is an important one, is the so what question, for sure.
That's right. And we've developed a number of tools and resources, and we have been doing extensive outreach to a variety of healthcare professional groups and government and of various levels to make them aware of the guidelines and the resources that are available. But as David indicated, like the project is coming to a close on March 31st. So the implementation period is there's not active funding to support the continued dissemination to ongoing groups.
Although one of our projects in our knowledge translation committee was, how do we target policymakers? And so that has been a focus, actually. Not only we had groups that were focusing on how do we reach people living with post-COVID, how do we reach other healthcare organizations? But yes, we had one group focusing on how can we write these and reach them, policymakers. Yeah.
And on our website, we do have a full list of the different committees and groups and people who were involved in the different groups. I see some questions around the international guidelines and who were the international collaborators. So I believe that's posted under our Meet Our Team under committee members, I believe. The International Advisory Board members are all listed there.
Maybe while we're waiting, we could have someone just show the website on the screen. I don't know if that would work.
There was actually two international advisory boards. There was the International Advisory Board, and then there was the other group that Dr. Schoenemann was leading with the, it was called the ICPCC, I believe, that group as well. And we haven't added that information to the website. It's under development right now. I just want to indicate that there are going to be a lot of updates coming to the website over the next 10 days or so. We have a lot more resources that are going to be available in a variety of languages, French, English, as well as a number of other languages as well. So I encourage everyone to continue to check the website because there will be a number of resources that will be added, including webinars and listings and continuing education courses for healthcare professionals as well.
All right, well, Heather, I think it's back over to you.
Yes. So if there are no further questions, I just want to thank everyone for joining us today. Don't forget to continue to visit CAN-PCC.ca. As I mentioned, we'll have a lot of other resources that are going to be continued to be posted. We also have one more webinar coming up on the pediatric recommendation this Thursday. Please review our newsletter signups to stay up to date with all of the releases coming up, as well as new projects that we hope to update you on. We also want to hear your thoughts on today's session. So please take a moment to fill out our feedback survey. It helps us improve our webinars and to better serve you. So we hope to see you on Thursday for our next webinar.